Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
My name is Ashley Ellis. For those of you who have not met, I am an assistant dean in the College of Pharmacy for Strategic Partnerships and Innovation. So always say my favorite part of my job is I get to get in my car and go meet people in the community and make alliances and things, especially with primary care and ambulatory care, that help people in the state of Tennessee to be healthier, especially to deal with chronic diseases. That's what we're going to be talking about today. And in the Tennessee Heart Health Network, my foot in that department, in Population Health Consortium, is also to help with innovation and really on the billing and coding and sustainability piece. And so it's my pleasure to introduce to you today Dr. Reverend Jonathan Lewis, who I have gotten to know both professionally and personally. We're both members of the same church, so it's really been fun to get to know him and to listen to him, be inspired by him. But he's the director for community partnerships at Methodist Le Bonheur Healthcare. Did I say that all correctly?
Yes.
Okay, wonderful. So he has a really cool job too. We probably have some similarities in our jobs, but he's going to tell us about this really cool program that they have partnered with the Tennessee Department of Health that they have implemented here in Shelby County and in Tennessee. So I'm going to let him take it away. Let me know if you have any issues sharing your slides.
Sure. Thanks, Ashley. Thank you for the kind introduction, and thank you also for inviting me here today. Really excited to present and to tell everybody about what we're doing with the Chronic Disease Self-Management Program. Let me go ahead and give the acronym introduction for that. I'll try not to use too many acronyms, but I will definitely use this one repeatedly.
Don't worry, because at UT we love them. We love them.
That's good to know right at home. The one I will use over and over again probably is CDSMP, which is short for Chronic Disease Self-Management Program. So do know that that's mostly what I'm talking about today. I'll pull up the slides in just a second. Do just want to say a little bit more about myself and what I do in the community, and in case you run into me anywhere else where that might have been. As Ashley said, I do work full-time at Methodist Le Bonheur. I've been there for 16 years, and I started at Methodist as a chaplain. My training was as a clinical bedside chaplain, which I did for the first 7 years or so of my career at Methodist. And then sometime in the mid-teens, started moving more to sort of a community outreach role, which is really exclusively what I'm doing now. I'm not at the bedside anymore doing clinical chaplaincy, though I often tell people I still sort of think of myself as a chaplain and sort of do things in the way a chaplain would do them. And there are some aspects of the program that I'm talking about today where I really kind of see that at work in the relationships that we get to form with people in the community. And that's one of the things that I really like about it. The things I'm working on most currently at Methodist are CDSMP and also our Congregational Health Network program. If there's another acronym I use, it's probably that one, which would be CHN. And I've been working as the director of CHN for about 4 years. That also is not just an aside. I will talk in the slides today about the connection between CDSMP and CHN, sort of how those are working together. But a lot of people who have worked with me in recent years on community projects, on inter-organization partnerships, have probably worked with me in the capacity of the CHN and partnering with churches in the community to do health initiatives. That is still a very large part of what I do and of what my team members work on. And that includes sort of integrating CDSMP into our church relationships. And like I said, I'll say more about that in a bit. Let me stop there actually, just before I jump into the slides, because I think once I do, I will probably flip through the slides and then come back to sort of questions and conversation later. But before I pull them up, let me see if there's any questions that anybody has just about me or anything I just said by way of introduction or things I do at Methodist.
I did forget to mention that you also work with, is it Rhodes as well, that you lecture there, teach there?
Yeah, that's really something that I really love doing. I teach a class at Rhodes College. It's called Pain, Suffering, and Death. Usually when I tell people the title, that sort of gets a reaction one way or the other, but it's in religious studies at Rhodes, and it's actually been a course there for many decades. I've been teaching it for about 3 years now, and I really like doing that. Just started a new group a couple of weeks ago. Yeah. Okay. Well, let me get to these slides and just say that because I'm just on a laptop here, I'll be looking at my slides and probably won't see a lot of what's happening in the Zoom window in terms of chat and things. So I will probably...
I can monitor that for you if you'd like.
Yeah, thank you.
Okay.
And
yeah.
I'll probably be trying to get through the slides relatively quickly. I am much more interested really in talking to you all, answering any questions, hearing ideas that you have about the program than I am the sound of my own voice. So I'll try to get through the slides and get to the latter part as quickly as possible. So let me start the share here. All right. Ashley, I can see you. Does the share look okay?
Yes, perfect.
So, again, Chronic Disease Self-Management Program, CDSMP for short. We, as some of you will know, we didn't come up with CDSMP. This is not a curriculum or invention of our making. CDSMP is an evidence-based program. It is used literally all over the world. It is a sort of small group, cohort-style educational vehicle that is used to do health education with people. Usually a cohort takes 6 weeks, and so you enroll a small group of participants, anywhere from maybe 5 to 15 people, and that group of participants meets once a week for 6 weeks to go through the curriculum. Again, the curriculum is used all over the world and is proven to be very effective. This is actually sort of the second time that Methodist Healthcare has done CDSMP in the community. We started doing this work in 2018, 2019, something like that. It was really going quite well. We were doing it especially with CHN churches and community members and getting a lot of really positive feedback from them. COVID really was the precipitating factor that sort of put the meeting of those groups on hold for many reasons. And it's really just been now in sort of the post-pandemic that we have resumed it. And we have done so, as I think Ashley mentioned, with grant support from Tennessee Department of Health. We got a grant from them late last year that we are using to fund these groups and the staff that we have working on this and the various costs related to the program. And so the way that we are approaching that thus far is we are having sort of rounds of classes occur throughout the year. So during any given round, we probably have 7 to 9 different CDSMP classes meeting all over the community. We just started with our first round in March of this year. So this hasn't even been going on for a full year yet. And even just in the 6 months or so that we've been doing it, we just finished our 4th round. We will start our 5th round next week. And in that time, we have enrolled about 500 community members in these classes. And so basically the plan is we will continue every 7 weeks. I told you the class takes 6 weeks, and then we have 1 week for our team to sort of catch up on things in between classes. So every 7 weeks, we will enroll a new group of participants, and we will do that for at least the next 2 years, which is how the state of Tennessee is. And we have a lot of plans and prospects already, actually, to do this work much beyond that 2 years. But we know for sure that we are funded and planned through basically the summer of 2026. That carries a goal of us conducting at least 150 CDSMP classes around the community. A lot of ways and reasons to believe that we will exceed that goal, but that is the number that we're shooting for over the life of our grant. One of the really nice things about these cohorts is that they are completely open to the public. We obviously are employed and supported by Methodist Healthcare, but there does not have to be any connection to Methodist Healthcare in order for someone to enroll in one of the classes. You don't have to be a patient. You don't have to be referred a Methodist doctor or anything like that. These classes are completely free and open to the public, to anyone 18 or older. Really, the only prerequisite for being a part of the class is that you self-identify as dealing with a chronic condition of some kind. That can be really almost anything, from cancer to heart disease to arthritis, to asthma, anything that is a chronic condition. If you self-identify as dealing with that, then you are a great candidate for CDSMP. Even for that, we don't need an ICD code. We don't need a doctor's letter documenting the diagnosis or anything like that. If that's something that you are dealing with, then you can be a part of CDSMP. Not only can you be a part if you yourself are dealing with a chronic condition, but also we can enroll caregivers of people who are dealing with chronic conditions. So if you yourself have the condition or you're a caregiver for someone who does, then we would love to talk to you and to see if CDSMP is right for you. We have these cohorts taking place in as many different places and venues and ways as we possibly can. We are doing classes in hospitals, community centers, churches, libraries. We are doing them not only in person, but we are doing virtual cohorts, and those are going really well. We are doing cohorts not only in English language, but also in Spanish language. We have 2 fully bilingual team members that are doing what's called Tamondo. Tamondo is the Spanish-speaking version of CDSMP, and we're doing those as well. So English or Spanish, in person or virtual, at a community location, at a healthcare location, we are taking this far and wide, and I'm really pleased with the accessibility of the program. Just a little bit about sort of the foundations for this, which are probably fairly evident, especially to people on this call. This is very much based on the Community Health Needs Assessment that Methodist Healthcare last did in 2022, if I'm not mistaken. Basically, every need that was identified on that report is directly and effectively addressed by CDSMP, and certainly the top 2 leading causes of deaths in our community, which were heart disease and cancer. This also directly aligns with the mission at Methodist Lebanon Healthcare, with the strategic plan we have to provide quality care to patients and families. And also to extend the resources to our community in as many ways as possible, and also with the goals of our program that we launched Labor Day last year, which some of you may have heard of, called Healthier 901. CDSMP directly aligns with that as well. And again, sort of the one of the missions of CDSMP is very similar to the mission of a lot of our other community outreach programs, very similar to the mission of the Congregational Health Network, which in general is to extend the resources, education, and interventions of our healthcare system as far outside of the walls as possible, to try to reach people, to meet people wherever they are, in hopes that we can practice some prevention in addition to intervention. We do have a bit of what I'm calling on this slide the MLH approach to CDSMP, in that we are doing every bit of the CDSMP curriculum in the way that it is planned and prescribed that it should be done. But we're also sort of adding some things on top of and around the curriculum. So if you enroll in one of our CDSMP groups, you are not only going to get the chronic disease education and resources, but you're also going to get some other things. One of the assets of the program that is built into the CDSMP curriculum is the trained facilitators, the trained educators that you get to learn from in the classes. These classes are taught in pairs. So every single class has a pair of trained teachers that are leading the participants. And over the course of their training and of doing these over and over again, these trainers really gain a lot of expertise quite quickly on the sorts of questions and conversations and needs that come up in the classes. And people really are going to learn a lot just from the interactions with their trainers. In addition to those interactions, people are also going to learn a lot from their peers. One of the major sort of components of CDSMP is interaction with the other participants. One of the major components is action planning, and people really practicing, setting goals that make sense for themselves, practicing those goals in action in sort of the week in between their class meetings, and then returning to class the next week, talking about how those action steps took place, things that they want to try for the next week when they do that again. There is a lot of support and feedback that happens both inside the room during class time and also sort of in between the meetings. And over the course of the 6 weeks, these groups often sort of quite organically develop the kind of community and support that really helps people succeed at what they're trying to do. While in class, we provide healthy snacks for people. That, of course, what comes along with that is sort of some education, of course, on nutrition and the importance of that, which is a major, major component of the course. In addition to the healthy snacks, people always walk away from the course with some things in hand, and not the least of which are their sort of educational CDSMP manual that they get to keep. Also things that we have for them, like cutting boards and portion plates and things like that. People really sort of walk away with some really helpful tools in addition to the education that they get. Probably the major thing that we have sort of added onto the chronic disease education is the social determinant screening. Every single person that enrolls in one of our CDSMP groups is getting screened for social determinant of health needs. If they screen positive for any needs, we talk to them about referral to community providers where they can possibly get intervention around those. That's optional, of course. We are helping people with SDOH needs to the extent that they want help with those. But that is such a need in our community and such a contributing factor to many of the healthcare outcomes. And so that is a thing that we wrote into our grant and that we just felt was very important to do as we're trying to help people with the various things that are affecting their health. So in addition to the chronic disease education, we are doing this social determinant aspect with every single person who enrolls with us. We are able to pay for transportation for anybody to get to the class as an example of one social determinant that affects people's health, not alone, but also affects people's ability to access programs like ours. So we're able to pay for transportation for people if that's a barrier. We also have a really outstanding resource at Methodist Healthcare called the Living Well Network. I would love to tell anybody about that. If you don't know about it, that's not what the presentation is about today. But it is a really, truly outstanding mental health screening and referral resource that is 100% free and 100% confidential for absolutely anybody in the community. That is really our chief referral for people who also present with mental health needs that may be affecting them in the midst of their chronic disease. And so in that way, we are really trying to build sort of a wraparound solution for these communities that we're creating through the program. You're getting the chronic disease education, you're getting the really valuable teaching and expertise from the program and from your leaders, you're getting the support from your peers as everyone works individually and as a group on their sort of goals and how this can, create new habits and better outcomes for themselves. You're getting screened for social determinants and being connected to community resources that can help with those. And you're also getting connected to mental health experts to the extent that that is something that people are presenting with. Not only that, but we have been really blessed with the grant funds to be able to offer graduation incentives for people. As I said, these meet for 6 weeks. If you attend at least 4 of the 6 classes, then you are considered to be a graduate of CDSMP. And if you graduate from our program, we are able to provide you with an $80 gift card to your participation. So all of those things combined really make a program that we think is very attractive to community members, that we are finding to be very attractive and successful with community members. And so we are just really excited to increase the awareness about it and make sure that people know that they can access it. On that note about sort of some of the early results and feedback that we're seeing from participants, we are really being told about a lot of successes from people that have enrolled with us. Just as one very small example, I have this screenshot here of a text message from one of our participants who made a healthy plate at an event they were going to and was just so excited about that and wanted to text their CDSMP facilitator and talk all about it. That is not an isolated incident. We are really seeing that sort of excitement and outreach to not only to CDSMP leaders, but also to fellow class participants. People are coming to class, sort of talking about the different things that they're trying to sort of reach the goals that they want to reach. And, that's exactly the sort of traction that you want to see with a program like this. In the red box here on the slide, I have just quoted an email from a participant that was at Middle Baptist Church in South Memphis. It was one of our very first cohorts we did. I said, hello, just to follow up to inform you that our first workshop was a huge success. I received only positive feedback as to the quality of the information received and the helpfulness of the practical goal-setting exercises done in class to help manage chronic diseases. We are looking forward to our next workshop starting July the 30th. They were doing this in the spring and made sure that we knew they wanted to do another one in the summer. If possible, I would like to schedule another class after the July 30th workshop. It indeed, our friends at Middle Baptist have continued to be very engaged with the program, as have many others. Another example of that is there in this red box, I just wanted to extend my sincerest thanks for the fantastic workshop. The insights shared have truly been invaluable to me. Classes meticulously planned structure and seamless flow made the learning experience truly delightful. I've downloaded the Healthier 901 app. I mentioned the Healthier 901 program earlier. I'm eagerly looking forward to our next group gatherings. Once again, outstanding job. We do have an average. We do a lot of feedback. We have a lot of evaluation tools that participants are giving us, both about the quality of the curriculum and the resources, also about their experience with their instructors. And so I'm really sort of sparing y'all a lot of the data. I've got a lot more data than what we have in these slides, but we really are hearing very good things. Out of 106 respondents from our sort of early cohorts in the first part of this year, 103 of them rated their instructors with a 5 out of 5 stars. And that rating has continued through the summer and into the rounds that we're seeing now. In addition, one of the numbers that really continues to be very high is our graduation rate. Currently, that is at 85%. And all that means is, it sounds like, basically, of people who attend at least one session with us, 85% of those are actually graduating from the program. This really is my first experience with CDSMP, certainly my first experience being kind of a program leader of a community-wide plan to offer CDSMP. So I didn't really have a lot of experience with this beforehand to say like what would be a good graduation rate or wouldn't. Since starting the program and talking to other, health leaders that I know about their experience with doing CDSMP in various different communities, sort of when I mentioned the graduation rate of 85%, I get a lot of questions like, how did y'all do that? I've been told what I'm telling y'all, 85% is a very, very good number. So we're really excited about that and are trying to put as many things in place as we can to sustain that number. Just a little bit more data on things that we're hearing from our participants. This is an example of some of the questions that we ask participants on a pre-test and a post-test to just kind of measure their own evaluation of their progress on these various items. And you can see on questions like self-management of overall health, stress, of diet, of activity, communication with your healthcare provider, knowledge of community resources. These are all things that are focused really heavily in the curriculum over the course of the 6 weeks. You can see on every single one of those, our participants on average are reporting a improvement in their ability to self-manage those. In some cases, almost a 25 or 30% improvement on those. Why do I have the only items that don't report an improvement highlighted? On management of pain, our pre-survey average has been 7 and our post-survey average has been 7. On management of sleep, pre-survey average has been 6 and post-survey average has been 6. I highlight those to say that I think we are getting honest feedback from our participants. On pain and on sleep, they're saying, you know what? Those are about the same for me after the workshop as before. I take that to mean that if that were the case on the others, they would tell us that. Those are also areas that we're looking at, how we can offer even more resources around that. Is there a way that we can get people to feel like they are managing their pain better, that they are sleeping better? That's something we want to look at, but also on all those other items, I think if people didn't feel that they were better managing those, they would tell us. So we're really excited about that data so far. This gets into a little bit of where we're finding participants for these classes. The Get Well Network is a basically TV screen menu that is used in Methodist hospitals. And so we have sort of a prompt that appears on TV screens in the hospitals for patients and families about CDSMP. And this is just some of the data that they have provided to us on sort of what the interaction on that has been. Not going to dig into these super, super close, except to say that we really are getting quite a lot of sort of what I would call, kind of a cold call type referral from people. They're not talking to us on the phone. We're not meeting them at community meetings. These are people that are seeing nothing except a sort of banner prompt or flyer or advertisement on a TV screen while they're in the hospital. And really from that, we're getting quite a lot of engagement. You can see that over the course of about 6 months, nearly 3,000 people across Methodist hospitals have clicked the Learn More button on a CDSMP prompt. The other table over there to the right, nearly 500 didn't just click Learn More on something that sort of popped up and kind of demanded a response, but sort of manually navigated to information about CDSMP and sought more information on that. And so just to say a little bit more about kind of where folks are coming to us from, as I said earlier, because of our CHN program, our work with congregations, we do quite a lot of work with pastoral leaders in the community and offer all sorts of health education and resources to them. We are certainly doing a lot of CDSMP in churches and with people that we know through our church relationships. But that not only is not the only place that we're doing this, but really we're seeing sort of quite a balanced array of referrals and sort of recruitment sources for CDSMP. So far, we have done a lot of very kind of grassroots promotion of the program, literally ourselves going physically to grocery stores or libraries or community centers, setting up a table and talking to people that walk by. And when we've done that, we've gotten quite a lot of signups for the class. Again, not people that we really have prior relationships with, not people that are being referred to us by trusted physicians or healthcare providers, people that really sort of meeting us for the first time, almost certainly learning for the first time what CDSMP is, are signing up with us and then are coming to the class and then are graduating. That's obviously what we want. And there's really quite a lot of reasons to think that that can continue over the life of the program if we continue to have the resources to offer it. So this table just sort of shows some of the various referral sources we've had. And what we've been really excited to see is that they're sort of coming from all sectors of the community. So this is just an example of one of our kind of recruitment flyers. That certainly can be shared with anyone on this call and anyone in the community for that matter. People can call us, they can email us, they can scan a QR code to express their interest. We would love to talk to anyone and everyone, not only to people themselves who think they want to enroll in the course, but also people who have networks that they are interested in referring people to, providers who think they might want to refer their own patients to programs like this. We would love to provide any resources that would be helpful to increasing the awareness about the program. One of the really interesting and exciting sort of upcoming phases of this program is that starting next month, we are going to have 5 of our team members certified as CDSMP master trainers. Right now, we have 13 or 14 people that are certified as trainers, which means they can teach the classes. Master trainer means they can train other trainers. So we are very soon going to be able to train community members to teach these classes as part of our program. They are not going to be Methodist healthcare associates. They don't have to be full-time healthcare workers or, clinical professionals of any kind. if they are a community member that is at all interested in doing this program, we can train them to be trainers, and then we can provide them with the resources to run CDSMP cohorts. That, of course, could ramp up our activity level quite quickly, which is something we want to do. We've got to come up with our own strategies about sort of how to manage the increased sort of data needs and things like that. But that's going to start very soon. And not only can we train people to teach the classes and provide them with the resources that they need to sort of set up the classroom environment and offer the educational resources and things, we also can pay cash stipends to people who teach the classes as part of our program. So, as I said, that's a really exciting sort of phase 2 that we are about to embark on, and really is a way that we could potentially interact with people on this call who maybe are interested in the program, not only as a way to sort of, connect people that you know or that you think might benefit from the program, but maybe you yourself or someone would be interested in being an instructor. And if that's the case, we'd love to talk to you. We will soon have the capacity not only to train you to be part of what we're doing, but also to make some cash while you do it. So that is really a kind of major expansion that is coming up for us very soon. Okay, that is the end of the slides. I am going to stop the share, and I'd love to take questions or ideas or feedback from anybody.
That sounds great. We did have a couple in the chat, if we want to use that before to warm everybody up. That was a great presentation. Okay, one question was, so how are you achieving those rates of graduation? That is really high, for those of us that work in the community or like outpatient settings. Sometimes it can be hard. So I know you're doing the stipend, the FUCI 4 out of 6. That's probably a good motivator. What are some other ways that you're helping to encourage people to come back?
Yeah, I see Jamaica here, who is our outstanding program manager. Jamaica, I want to come to you on this in a second. Ashley, certainly the graduation incentive, the gift cards are helping people stay engaged with the class. That is the definition of an incentive, and we're really glad that we can offer that. Also, like I said, we can pay for transportation. I think removing barriers as much as possible is something that's going to help people, get to class again and again. And the other thing that I would say is the community that is formed. We really are getting good feedback about the relationships that people establish with their trainers and with their class participants. And, I think that's another thing that sort of keeps people coming back. Jamaica, do you have any other notions as to how we're keeping that graduation rate so high?
Jonathan, I think you touched on the main points. Really, our strategy is just developing relationship with our participants. We reach out to them on a weekly basis, check in with them, and we follow up with them regarding their action plans that they developed the week prior. So every week in our sessions at the end, and sorry, you guys, there may be folks talking in the background that you can probably hear. But every week we develop action plans. And so these are mini goals that participants develop themselves, right? And so our leaders follow up with them regarding those action plans. It's a quick 5-minute call, nothing very intense, but just that point of contact, I think, is one of the main reasons why we're able to maintain our high graduation rates. And also, we have great leaders. They are extremely engaging, and the amount of participation that participants are able to engage in, they build a sense of camaraderie in these workshops. And so they want to come back and see their friends as well, right? They're developing relationships with one another as well. So really, it's all about the relationship building.
I know, like, for me, you may experience this too, but for me, when I was teaching like DSME classes, DPP classes, especially when the patients and participants would experience wins in their action plans that they develop themselves. And it doesn't have to be a clinical win. It could be, I did go walking 3 days, or I did buy those tennis shoes we talked about so that I could go walking, at the church. They want to come back and tell their friends about it. Or, me and my friend here, we did the grocery store tour that you talked about and share it with maybe the guide or whoever. And they're so proud of that. And that really builds that type of community that really makes people want to keep coming back. Okay, there's another question in the chat that says, are there virtual classes for this program, and how far into the state do you plan on extending the program?
Yeah, answer to the first question is yes, we do have virtual classes. We're doing virtual classes every single round. And I might say, and maybe did mention, that I'm just having a really good experience with those, actually. If I sound a little bit surprised, I guess maybe I am. Obviously, there's something that happens in an in-person environment when you're with each other that I sort of counted on going well and has gone well. With a virtual class, you just never quite know sort of how things are going to translate, digitally. Boy, we have just really received really good feedback from people that are in the virtual environment, are still really engaging very thoroughly with their trainers and with their co-participants. And those virtual classes are going really well. So yes, we are doing those, and we'll continue to. And there's even a scenario in which the virtual class, is could become even more popular, and because of the accessibility of it, it might be something that we do even more of in the future. Sort of gets to this part of that question that how in the state do you plan on extending the program? Who knows? Maybe to the Smoky Mountains. Let's just get all the way over as far as we can. Right now, we are pretty well focused on Shelby County. We have some dreams to get into surrounding counties contiguous to Shelby County, and think that we will probably be able to do that soon. We have talked to 2 friends at the Department of Health in Nashville and in Chattanooga about how this could potentially get, especially virtually, could get to places many, many hours from where we are, but still in the great state of Tennessee. That is a future aspiration. It is possible. It's not something that we're going to be doing anytime really, really soon.
Do you notice, I'm going to ask that second part of your question, Virginia. Do you notice a difference in demographics between virtual and in-person participants?
I don't know that we've seen a marked difference in those 2 groups. Jamaica, jump in and correct me if I'm wrong. We have a lot of data on that as well in terms of the demographics of our classes, sort of the average age. Some really cool tools actually that kind of map zip codes for us and sort of show us, where people are participating with us. I don't know that we have seen any major noticeable demographic differences between virtual and in-person classes.
If there are any differences, because our virtual workshops are usually held after work hours, we tend to see folks that are still in the workforce that are taking our virtual workshops. Typically during the day, if you're holding a workshop at a library at 9:30 a.m., right? You probably are tapping into our retired community. But so the people that usually take our virtual workshops, just because of the time that we offer them, are usually going to be folks that are still in the workforce.
That's kind of what we're noticing at our health hubs. Gladys, you can jump in, or anybody else. So like, depending on our exercise classes, or I mean, even some of our health coaching things, people that are working, you know, or I mean, they may be working, but they still don't have insurance, or they have high deductibles. Underinsured people, they're wanting to come kind of those after 5 or a weekend, that kind of stuff. I mean, even if it was me, I'd be like, just if it's virtual, I can do it on my lunch hour, or I could do it at 8 a.m., or I could do it at 4. That's when I want to do my eye doctor appointments, stuff like that. But I don't want to take a whole day off to go to something like that. But yeah, those are the type of people. But if it's at like you said, 10 a.m., then you're going to get your Medicare type people. But so Virginia's response was, it seems like a great program, and she's in Chattanooga and very interested. Jennifer Ride says, what do you think are the most common chronic conditions that you see for your participants? And do you have a difference in gender for participants, females versus males?
Yeah, we definitely have had more female participants than male participants. That is a trend we have seen. Definitely not just like 0 male participants, but it's been more female for sure. Chronic conditions that we're seeing in the classes are very reflective of the chronic conditions that are most common in the community. We have had what I would call a pretty representative sample in the classes, which is another really great thing about CDSMP, that it really has created a curriculum that is helpful for someone dealing with any chronic condition. So whether it's heart disease, cancer, arthritis, asthma, diabetes, hypertension, etc., the things we cover in class are helpful for really all of those. To the extent that a class member really needs to create action plans that are very specific to the needs that they have, that is also sort of built into the program. So it really sort of combines that universal and specific aspect to make a plan that works for everybody. So that's one of the things we really like about it. And we are definitely seeing sort of all of those in the classes.
Excellent. Does anybody in the group, feel free to come off mute. You don't have to just put it in chat.
Yeah, I have a question. So thanks so much for the great presentation, Dr. Lewis. I have a question about your evaluation plans. So apart from the satisfaction surveys and the pre and post surveys, are you planning to follow up with the participants in the future? Like, for example, are there any specific outcomes that you want to check pre and post program?
Yeah,
to measure your impact.
Yeah, we do really want to do that, and in fact, one of the aspects of this that we're really excited about in terms of the possibility is kind of the creation of a community, sort of a community within our community, participants, instructors, people that have been part of the program. We really want to sort of keep that community alive. We want to stay in touch. We don't want it to be, 6 weeks and then never see you again. So we are working with a lot of ideas about communication channels where we can stay in touch with our participants long after class is over. There's many reasons for that, but one of them is so that we can do kind of long-range follow-ups with people to see how the program is still working for them, what sort of resources would still be helpful. So we definitely want to do that. Having just started with our very first cohorts a little over 5 or 6 months ago, we haven't even yet hit the point where we would be, sort of starting to capture those long range goals. But that'll be coming up soon, and we do want to do that. Really, even another aspect of that would be the potential to capture clinical data with an EMR. That is yet another level, of course, of sort of technical expertise that we have not yet really unlocked. We're interested in exploring that, and that may be something for the future.
Okay, thank you.
I did have something else. On the slide you were showing about the 2 questions on the survey that looked like they hadn't moved were sleep and pain. We still have a pharmacy student on here?
Yes.
Okay. I don't know if you and I had the same thought, but when I saw that, I was like, okay, well, both of those can be fixed with medicine or exercise. Those are the two. I mean, to me, those are the 2 things. So I don't know. So what kind of discussions do you have in the curriculum about that? Or, Meg, do you have any thoughts on that either when you saw that?
Not a lot. I did think it was interesting though, I guess, but I also thought it was maybe something that maybe isn't a big, or I feel like when I think of like this type of these sessions, I do think of like exercise and like diet and stuff, but I wouldn't have really thought of pain and sleep, so it didn't seem like super surprising to me, I guess.
Right. Because they're not focusing on, I mean, I wouldn't think you'd be focusing on like medication optimization or stop or, dosing or anything like that, because we're focusing on like the lifestyle type stuff. But I wondered if that might be why they're not. Just from a pharmacist brain. It's hard to get out of your pharmacist brain.
Yeah, it's again, it's maybe a bit of a interesting presentation technique for me to literally highlight the 2 things where people are not reporting improvement. Again, I explained to you all that the reason I do that is because that in some ways sort of validates for me the positive feedback that we get on the other pieces. I agree with you, Ashley, that both medication management and intervention and also exercise, separately or together, do seem like good strategies to, sort of try and move the needle on both of those items. We're definitely interested in seeing if we can change those highlighted items to unhighlighted items in the future. I think that's possible, but so far, probably for a number of reasons, some of which y'all just mentioned, those have been the items so far that people have felt like have stayed roughly the same on average from beginning to end of cohorts. So we'll see.
I think it's important to just acknowledge that CDSMP isn't a magic bullet, right? Like, so we are teaching people strategies that they themselves can implement in their own day-to-day lives. And as much as we'd like to walk with them really closely to help them implement a lot of these strategies, the hard work is on the participant. And so, we give them all of these tools and we tell them to put them in your toolbox. You may not need this hammer today, right? Today you may need a screwdriver. And the screwdriver may represent medication management or stress management or dealing with difficult emotions, whatever the tool may be. But tomorrow you may need a hammer. And so just giving them all of those tools, they walk away knowing that this is a long-term, day-to-day awareness that I need to walk into life with now at this point, right? So they walk away with all of these tools that they know that at any point in time, if they need them, they can reach back into their toolbox and they can start to implement some of those tools. So, it's not a magic bullet, but it certainly leaves participants feeling empowered, to knowing that, hey, I can do something about this and I can do something about that. And those issues that may not necessarily improve over the course of this 6-week workshop, I still have tools that I can utilize in the future. I can go and talk to my doctor about that, right? Like, I know how to advocate for myself a little bit better so that my sleep can improve or so that the pain can improve. So while we want to see those pain numbers improve, I'm encouraged just knowing that they have those tools.
I totally agree with you, Jamaica, and it's not a silver bullet, because I don't think that exists, honestly. I think that's unrealistic expectations that anything would fix everything. But, what you're talking about is such a great supplement to the medical model, because I've just seen so many times where it's like, you go, let's say that a patient goes and they find out they have prediabetes, and then the physician says, you need to lose 5 to 7% of your body weight. And this is a 10-minute conversation and they leave. I'm like, okay, well, what do I do? Keto, paleo, Weight Watchers, Google, diabetes? I don't know what, And then you're just like, it's a Google. But like what you're talking about is kind of like a way you can view health information and view taking care of your body. And I think that makes the patient the powerful one in the situation instead of that stuff happening to you. That's really cool. So with that, we've got 4 minutes left. Do we have any other questions?
I put in the chat that I would love for the hubs to be part of the referral process. I'd love to have like a contact that we can send you guys, when we can't accommodate some of the patients, and at the same, we'd love to be able to be part of your network, and because we are teaching the same thing. So it would be great.
Likewise, we would love that. It'd be great.
Yeah, I think there's a lot of cohesion there and synergy. Wonderful.
This is great. Thank you, guys.
All right. Jamaica, will you put your email in the chat? Jamaica is our manager for the program. She is our schedule expert. She has all the referral resources. She would be a great contact for anybody about further questions about the program, making connections. Reaching out to Jamaica or myself could, I think, get you what you need.
Wonderful.
One additional thing that Jonathan didn't mention about our upcoming, what we call our lay leader training program, is we will also be training leaders in both English and in Spanish.
Wonderful.
I think that is extremely cool, and we are really, really excited about that.
Perfect. Thank you so much, Dr. Lewis. Thank you so much, Jamaica. Oh, go ahead, Gladys.
I'm sorry, just real quick.
Yeah.
Are you finding that you are getting a lot of Hispanic patients in the community, and where are they attending classes?
So the majority of our, as Jonathan has already said, we have 2 fully bilingual leaders that are really immersed in the Spanish community. And so we have partnerships with Latino Memphis and with lots of Spanish-speaking congregations throughout the community, Su Casa, World Relief, the list goes on and on. Our outreach efforts have really helped to solidify a lot of those relationships, and we continue to build. So we're really excited about the response that we've been getting from the Spanish-speaking community. It's very strong right now. the relationship that we have. And as a matter of fact, so right now we're about to go into our 5th round of cohorts. So that'll be cohort 33 through 42, I think. Next year we'll have rounds 7. I'm sorry, at the end of this year we'll have round 6. January we'll start round 7, and probably around in March we'll start round 8. We already have Spanish-speaking cohorts scheduled through round 8. So they are really, really excited about this program.
Love that. Perfect. Thank you.
Thank you so much, Dr. Lewis and Jamaica. You both shared so much information that's been helpful for our network. And this will be posted as a webinar on Tennessee, tnhearthealth.org. So looking forward to spreading more of your information. Thank you, everyone. We'll see you next time. Bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.